This type of fixation and the technique points that we'll be using this morning and this afternoon are applicable to a number of cases, and we can talk about the deformity correction with that as well and some of the key points. The LRS can be a very simple procedure, but it's very important to pay attention to the details and do it in a specific sequence, because you can get in trouble very quickly and it can be frustrating if you don't just go slow and do it in a good sequence. So the case in the presentation was 2 years old, and he had congenital short femur Paley type 1B. That just means that the femur is present but is short, and the ossification proximally is delayed. And in congenital cases, these are the most difficult type of lengthening. Post-traumatic cases are much more easy to lengthen because we're born with the genetic programming of a normal length of the nerve and the muscles. And so this child was evaluated in an outside hospital and sent to our center in Loma Linda, California, where we do lots of these types of cases, and we predict the limb length discrepancy based on the difference now stays proportionate to what they will be as an adult, and that was 287 millimeters in this case. So this will require several different lengthenings and possibly a rest at some point on the other leg. So we did the super hip procedure when he was almost 2 years old, and this involves reorienting the proximal femur, doing an acetabular osteotomy and some soft tissue releases. The valgus osteotomy was done with a plate, and then later hardware removed in order to prepare him for a lengthening procedure. We want to see that the acetabulum has an acetabular index of less than 20 degrees, flat or at maximum 20 degrees, and the neck shaft angle should be a minimum of 110 degrees. Many of these cases have coxa vera with like a 90-degree neck shaft angle, and that can cause issues with lengthening. And if there's any acetabular dysplasia, the hip can sublux very easily. So we need to really get it covered strong and avoid hip subluxation. In order to do the lengthening, the proximal femur needs to be ossified. We plan in general with LRS fixation or hexapod, Lizaroff fixation, to have 3 pins, bone screws per segment. It's really only necessary for stability to have 2, but we always want to have a 3rd because sometimes you can have pin loosening, infection, and this provides more strength for the cases where we're doing gradual corrections or lengthening. And specifically for the CFD, congenital femoral deficiency cases, we want to have a hinge over the knee joint because the knee can also be dysplastic. They can be missing the anterior cruciate ligament, and so we want to protect the knee, and the hinge likely will do that as well for the lengthening over nail case. And then we can correct up to about 20 degrees acutely in these cases, even when we're doing lengthening. So we can put the fixator on and do some deformity correction acutely, and then just do a straight lengthening. The first lengthening in these children, we like to do it before the age of 4 years old. The psychology is a little bit more harmonious for doing the lengthening at that age. The children just accept what mom and dad tells them. If you have children that are between 4 and 6 years old, sometimes they're too smart and then they start resisting your instructions. But when they're young, then you can be the boss and tell them what to do, and it's an easier time to do it. Once they become 8 to 10 years old, they're mature enough to consider another lengthening. That can understand the importance of it and the benefits of doing a lengthening, and it becomes easier. But avoiding that age between 4 and 6 years old is helpful. Our patient today is 4 years old, and sometimes we don't really have a choice, but we have to be prepared for that. Knee range of motion before surgery is 10 to 130 degrees in this case, and we hope to keep it that during the lengthening. When the lengthening when patients start developing a knee contracture during lengthening, it should be slowed down or stopped therapy in these cases we do 5 times per week. So I can't stress enough the importance of therapy. I know that it's difficult sometimes. If we have patients that come to our center for lengthening, they stay in the accommodations next to the hospital if they come from far away. So we do the therapy at our center, because other places, if you don't know who the therapist is and you don't have direct relationship and can't monitor the situation closely, you can get into trouble. And a stiff leg that is longer is worse than a short leg that works good. So it's very important to stress the therapy and not just trust it to somebody that you don't know. You have to have direct relationship with the therapist. If the knee develops a 30-degree contracture or it can't bend beyond 70 degrees, then we will stop the lengthening. Sometimes the lengthening can be restarted if the motion is regained, but it's very important to know when to stop and to be able to deal proactively with the complications. Let's just talk a little bit about some of the key technique points. For this case today, we're going to drape one extremity. We have supine position. Sometimes we bump up the hip just a little bit to make it easier access on the table to put the fixator. We prep entire leg with the foot and make sure we have plenty of space in the surgical field. This is a unique case because we're doing the hinge on there. If you're lengthening for trauma or just doing a deformity correction, you wouldn't need to do the hinge. But the hinge in these congenital cases is critical, and we start with localizing where the center of rotation of the knee joint is. And that happens to be right at a point right along the posterior cortex and the physis, the growth plate there. And so we start with the K-wire right at that point there, and just place a marking. It's just a broche to mark the point. We're not going to leave this in, but it just provides us a location around which we build the fixator. So this is the first step, and we take some time looking at the face and profile to make sure it's very exact both in rotation and orientation. And once we have that established, the case will get a little bit easier. On the AP view, it's important to know there's a handout that Shekawi made for you with a one-page tips and tricks page. And the first thing is planning and knowing how to analyze deformity, knowing the joint orientation angles. The mechanical lateral distal femoral angle is 88 degrees. And so if we want to, for these lengthening cases, we normally mount the fixator perpendicular to the mechanical axis. And that angle, since it's 88 degrees of the joint to the mechanical axis, we want this hinge pin to be perpendicular to the mechanical axis. That means that there's about 2 degrees of divergence of the joint. It's almost parallel. The wire should be almost parallel to the joint line. The joint can be in 2 degrees of valgus or 2 degrees wider on the medial side than it is on the lateral side, to be very exact. If the joint just diverges 2 degrees on the medial side, that means that this wire is actually exactly perpendicular to the normal mechanical axis of the distal femur. Yes?
Why we choose
the most precise, close to the growth plate, close to the end of the bone. Put that one in first, and then the second one is always at the opposite end of the fixator. We'll talk about why you don't want to do the one right next to it in a few minutes. But in this case, we have the hinge marking where we want the hinge to be, and then we're placing the most proximal pin in the fixator like this. So this one is just holding on where the hinge will be, and now we're placing this pin right here. And the pin in the proximal aspect of the femur should be aligned perpendicular to the mechanical axis of the proximal femur. In cases where you have deformity, you have to make sure that you're focusing on 2 different mechanical axes. There's a mechanical axis of the proximal segment, proximal to the deformity, proximal to the apex, and a different mechanical axis distal to the apex, defined by the normal mechanical axis of that segment, usually measuring off the joint, or if you have a long segment of diaphysis, you can measure off of that. But you want the fiche to be 90 degrees perpendicular to the axis, and also be conscious of rotation, because if you want to rotate the femur in or out and correct rotation, you can also do that with the LRS, and that can be measured. One other key point here is that many of these pins, fiche is tapered, and so if you put it in and you decide it's too far and you want to take it back out, it gets loose. So you should make sure that you're careful not to put it in too far, and you can't back it out. Some pins don't have the taper, and it's okay to back it out a little bit, but normally don't go too far in. So once we place that proximal pin, then we're going to go down and place the most distal pin, and that stabilizes the external fixator. If you were to place two pins close together before you place the other one up here, if you place a pin right beside this one, and it's just a little bit posterior, a little bit anterior, 1 millimeter of difference, so close like that will make 2 centimeters of difference over here. So that's why we always place one pin on this side, then one pin on this side, and then fill in the others. This case, with the hinge, it's a little bit more complicated, and we have some others that we can also discuss in between the cases. So the let me just mention, this we've made a small modification to this with a little. This hinge is resting right on the rail, and then there's a little bit of space. So this fiche here is a little bit anterior to where that hinge pin was. To answer your question, looking back at the lateral view, right here, our next, the pin for the next one will be up here, and the pins are in this area, even though the marker for the hinge is a little bit posterior to that. So that's why we put that hinge pin bolt right on the rail like this, and then this has the clamp, and so it elevates the fiche about 5 millimeters anterior to that. They even have something called sandwich clamp that you can elevate it even more. If you have a larger bone, you can put sandwich clamp and elevate it another 5 millimeters anteriorly if you want your pins even more anterior. Okay, so now we will place, we have one pin in the proximal fixator, one pin in the distal. Note that these are not parallel because this bone has a little bit of valgus deformity in it, and so we've purposely placed them a little bit divergent, and when we cut the bone, we will align them and it will correct the valgus deformity. So it's very important just to understand the concept of aligning this pin perpendicular to the mechanical axis proximally and this pin perpendicular to the mechanical axis distally. And if you align your pins to each segment perpendicular, you cut the bone, and then you don't even have to think anymore. You just put it in the clamp, lock it, and everything should be perfect. If it's not perfect, there's another clamp that hopefully we can show you today called the swivel clamp. And if you think now you have all your pins in there, it looks like this, all the pins, and you say, oh wow, I didn't line that up perfectly. There's a clamp called the swivel clamp, and you can actually angle the pins on the rail exactly where you want. And it's a little bit of forgiveness if you don't do it perfectly. So maybe a sign of weakness if you have to use this swivel clamp, because it means you didn't do it quite perfectly from the beginning, but it's okay if you need it. So in this case, and it's an easy place to put it, then we just use the mesh solide, and we can drill with this, no problem. But if you want to make sure you're in exactly the right position, it's very helpful to use the broche with the mesh cannulaire. So then we complete the osteotomy with osteotome, And we've also noticed here that we displace the osteotomy. Many times this is necessary because the apex of the deformity was down here, and so that means that the osteotomy is at a different level, and we have to displace it in order to be rotating around the point of the apex of the deformity. We do this percutaneously with osteotome and drill bit. The incision is approximately 8 millimeters in length. 5 to 8 millimeters is all you need, and drill several holes with a drill bit. I think we have an image of that. Maybe it's in the next presentation. Now is when we place the hinge. So you can see now we have 3 points of fixation in the proximal segment, 3 points in the distal segment, and also 1, 2, 3 in the tibia. And we keep them spread apart so we have good stability, different planes for good stability, and usually the pins are 6 millimeter pins even for these little children, 6 millimeter pins, but we have some pins that have a small filetage plus petit que 6 mm, but the shaft of the pin is still 6 because the strength of the pin varies by the quatrième puissance quatrième. The radius of the pin. So if you take a 6 millimeter pin and the radius of that is 3 millimeters, and you do puissance quatrième, you get the number 81. 3 times 3, 9 times 3, 27 times 3, 81. If you take a 5 millimeter pin, 2.5 times 2.5 times 2.5 times 2.5 is 41. So the relative strength of a 5 millimeter pin and a 6 millimeter pin is only 50%. 5 millimeter pin is 50% the strength of a 6 millimeter pin.
Okay.
So then once we get the hinge in place, we put the lengthening, we put the distractor on there and set it up. We make sure that the hinge is locked in place. We put we make some little modifications with some of the Elizarov equipment. We put that there so that this piece can't slide off. And I'm going to explain this little rod right here in just a moment. But let's finish looking at the pictures, and it will be easier to understand. So this is very important now that the knee bends without any constraint. If you set up the hinge in the perfect position, the knee should bend without any problem. And I think, let's see if we can make the video play here. Yeah. So you should be able to just drop it down and have it easily flex if you set it up correctly. If you don't have the hinge in the right place, it doesn't want to flex. And at night, we have the patients put this bar in place, and that holds the knee in full extension. And in the daytime, they work on physical therapy and they work on bending the knee in the daytime. What you don't want is the patient wants to be relaxed and wants to sit around with the knee at 30 degrees, or they think that they're doing a lot of good by doing movement like this. But what the most important with all of these lengthening cases is to do stretching in full extension and stretching in full flexion. So full extension, if the child or a patient's watching TV, they should put the leg up like this, and then they should put some weight on top of it. A big bag of rice or something, put on top here, and just sit there and relax. Work on extension, and then also they can work on flexion. So they can sit in a chair and they put the leg up here and scoot forward like this, and they stretch, sit for 5 minutes, stretch more, and work a lot on flexion, especially during the day. And at night, this bar here helps because it holds the knee in full extension when they're in bed, because otherwise they'll sleep all through the night with their knee at 20, 30 degrees, and you don't get the benefit of that. It's, the bone is easy for us to lengthen. The soft tissues always are the problem, and this is what you have to, I think this is the most important message. Doing the technique is important, but this operation is not done when the patient wakes up today from anesthesia. It's not done until they've done the full lengthening, and you have to think of it as an ongoing operation. And unfortunately, I won't be here to see the patient every couple of weeks, but we have good, reliable people here to be able to do that. And that's most important, is that follow up and being proactive with the therapy to avoid complications.
Okay.
If there's any